So the first thing is explanation as to what's going on. The second thing is examination and emphasis on the function of the joint. We have certain parameters when we examine someone with a jaw joint problem, which tell us whether this jaw is functioning well from a musculoskeletal point of view.
We're joined here today by Russell Mottram, a chiropractor with over 40 years of experience. He splits his time between Chiropractic Balance here in Hampton and Parade Chiropractic in Ocean Grove, utilising a holistic approach that blends traditional chiropractic with myofascial therapy, dry needling, craniopathy. Beyond standard care, Russell is a leading Australian lecturer and published author in the specialised field of the jaw, or TMJ, and craniofacial pain. He's recognised by the ACA, the ACC, and the American Academy of Craniofacial Pain, and he regularly trains dentists, physios, chiropractors, osteopaths nationwide, and soon to be international as well. Thanks for taking the time to have a little bit of a chat.
No worries.
Talk to us about what happens when the jaw is clicking.
A lot of people think that when their jaw clicks, or every time their jaw clicks, that it's doing some sort of damage to their jaw, or that their jaw is about to collapse. I personally would rather have a clicking jaw that is freely mobile, not painful, was not interfering with your ability to talk or chew, than a jaw that was maybe prone to clicking,
Yes.
but you were preventing it from clicking by what we would often call fear avoidance. You're not moving your jaw in a normal way because you are trying to prevent the clicks from occurring, which often leads to tension in the muscles, restriction in the actual movement of the joint, a number of things which are probably more disabling and more serious in terms of symptoms than the click itself. So just to go back to your original question, noises in your jaw joint, there's a few different types. The one which we probably call clicking or popping is caused by what we call technically a disc derangement in your jaw joint. Inside your jaw joint where the mandible sits, there's a socket here, and there's a process off your jaw bone or your mandible that actually sits inside a little socket which is right in front of your ear here.
Okay.
Very, very close.
Right. Okay.
So sometimes even when you have sore jaws or the jaw's not working properly, people feel there's actually earache and they end up
Ear stuffiness or...
That's right. They end up at their doctor and, sometimes they get put on antibiotics and things like that. And often that will prove to be not helpful because it's actually a musculoskeletal issue rather than an infective problem. On top of that little bone that sits there, just like in your knee where you have, everyone knows about a cartilage or a meniscus, we have a disc or meniscus that sits on top of that bone. I'll just grab the mandible here. I don't know whether you can see that very well, but that's the little process there where the mandible sits inside the little socket here, which is your temporomandibular joint. And on top of that, there's a little disc or meniscus, which is a hard, smooth, cartilaginous structure that when you go on, you open and close your mouth, our jaw has two distinct movement phases when we open and close. The first phase of opening, the jaw bone just hinges in the socket, okay? And then if we want to go wider, under the influence of certain muscles, the jawbone is actually pulled forward, so it glides forward, and when it's all the way open, the jawbone, or the condyle as it's called, is not actually sitting in the socket. It's sitting adjacent to a bony prominence at the front of the jaw joint. And it's the job of that cartilaginous disc to glide backwards and forwards with the bone in the process of opening and closing to make that frictionless and smooth. So it's sort of like hinge, glide, glide, hinge. That's the way our jaw works. And it's the job of that disc in the glide phase to stay in a secure position attached to the top of the bone of the condyle here by various ligaments, and that should be noiseless, frictionless, nice and smooth. However, for a variety of reasons, what can happen is that that disc can either be damaged or the ligaments that hold it in place attached to the bone here can become stretched or loose. And the disc itself can swing or shift into a position where it's now not sitting ideally located between the bone of your jaw and the socket here. And when that's the case, and you open and close your jaw or you chew, etc., the actual bone and the disc move in a relationship with each other that causes a pop or a click to occur as the bone and the disc are re-establishing a better relationship with each other, I suppose. So the short answer to a very long explanation.
No, it's good. It's good.
A displaced disc in your jaw joint
Yes.
is what causes most clicks and pops.
Okay.
Right? There are other noises, more grinding, rubbing sensations.
Yes.
The grinding sensation, or the technical term we have for it is crepitus, is often caused by wear and tear on not the disc itself, although that can be part of it, but actually the smooth cartilage which covers the bone of your jaw condyle and the socket. And this is a sign of early degenerative joint disease, DJD, or more commonly known as osteoarthritis. Often is something that occurs as people get older, but it can occur in younger people if the mechanics of their jaw has been dysfunctional for a significant period of time.
Okay. So we're not necessarily as worried about the clicking, the sound that it's making, but we're having a look more at its function, and we're being really aware if it is causing that crepitus, that grinding sound, that is indicative of probably disharmony or malalignment that's happening there in the jaw, and something we can...
Derangement is the term we use. Yeah. Which conjures up all sorts of images of mental derangement, but it's actually a physical disrelationship, disharmony, as you've used the terms. Look, it's not good to have a click, right? It's a sign of damage, but it's difficult to easily repair things that are causing a click. And there's lots of people go through their entire life with a click, and it never progresses to anything other than just an annoying click. It can be annoying, okay?
Yes.
I don't dispute that. It can be very annoying, especially if it's so close to your ear. And there are ways that we can try and diminish or have an impact upon the amplitude or the size of that clicking, etc. But it's actually something that's quite difficult to easily get rid of this side of fairly significant surgery.
Okay.
And the general rule of thumb is if your jaw is clicking, but it's not painful, it's not restricted, it's not impacting upon your ability to chew or talk, then it's something which we need to learn to manage rather than cure as such, because the cure is not really something that's easily achieved. And sometimes the process of having surgery, I mean, no TMJ surgeon as such would really recommend surgery for a click alone if the function of the jaw, there was no pain, it wasn't interfering with your ability to talk or chew. So if it's actually functioning okay, opening okay, etc., then, but it's clicking, we kind of try to demystify it. Often when people understand what it is, they become less anxious about it. There are some things, which we'll talk about shortly, I'm sure, that we can do to try to diminish the amplitude and severity of the click, although it is very difficult to actually eliminate it entirely.
Okay.
Having said that, epidemiologically, there's a spike in clicking jaws in teenage females.
Okay.
Okay. And there's possibly a whole lot of reasons for that. One is that that's kind of peak time for ligamentous looseness in young females. It's also a time of possibly significant stress around education, relationships, etc. So often there's a lot of clenching involved in things, which can be one of the reasons why the disc can become displaced in the first place. But all the research says that epidemiological spike is no reason for aggressive invasive therapy. All the research says that if we treat this conservatively, we manage function, we look at reasons for clenching and grinding, and try and deal with those, that the majority of those will sort of not so much self-heal, but they will often lose the click as they get older and their musculoskeletal system matures more.
Okay.
In their 20s.
In their 20s, okay. Let's talk about this conservative treatment that you alluded to, Russell.
Okay.
So what does, from your perspective, what does management or treatment look like of the clicking jaw?
Well, as I said, first thing is explanation.
Yes.
Demystification.
Always,
Because
yes.
so much of anxiety and distress around physical health can be associated with misconceptions about what's going on, which creates anxiety. Ironically, anxiety then creates tension and clenching, etc., etc. So the first thing is explanation as to what's going on. The second thing is examination and emphasis on the function of the joint. We have certain parameters when we examine someone with a jaw joint problem, which tell us whether this jaw is functioning well from a musculoskeletal point of view.
Okay.
Opening amplitude, taking the jaw from side to side, front to back, seeing how strong the muscles are with little muscle tests, etc. And this, as well as the history, of course, of how they're coping with chewing and whether there's pain on chewing and those sorts of things. So we would check and see that the jaw joints and muscles were functioning well. And our focus would be on making sure that those things were functioning as well as we could get them. So we have a number of techniques which are targeted at normalising or optimising jaw muscle function, whether that might be a hands-on physical therapy, certain types of deep tissue release massage, so-called myofascial therapy, which might also include dry needling. The lateral pterygoid, it's a muscle that when it's functioning well, it actually stabilises the disc on top of the condyle. Okay, so making sure that those muscles are working correctly is very important in stabilisation and coordination of the movement of the bone and the disc. In fact, one cause of the disc possibly being pulled into an abnormal position is tension and tightness in that muscle. And if we can release that muscle, often we find that the disc may reposition itself, which will make a difference to the clicking. May not eliminate it, but it might reduce its amplitude. There's also techniques where we can manually manipulate, adjust, whatever terminology you like to use, the bone of the jaw itself. It's to try to reposition the disc and the bone into a better relationship. Unfortunately, if the stabilising ligaments are damaged, we might be able to achieve that, but the tendency is for that instability to persist. So if there is instability or sometimes what we call hypermobility in a jaw joint, which tends to be the sort of joint which can end up becoming a clicking joint, then our focus is on stabilising exercises of the jaw muscles to add greater stability and motor control to function and movement in your jaw joint. So that's myofascial therapy, joint manipulation or adjustment, stabilising exercises, also some simple cognitive behavioural therapy techniques around clenching awareness in your daily life, okay? Because it's amazing the number of people who subconsciously clench in their daily life, and the little cognitive behavioural things that we talk about, I talk about a thing called teeth, tongue and breathing, where we try
Teeth,
to
tongue,
bring
and
awareness
breathing.
to what you're doing with your teeth, where your tongue is positioned and how you're breathing. And once you actually begin to explain this to people and make them aware of it and give them little routines for noticing it, it's amazing how often they come back and they say, I didn't realise how much I had my teeth closed. You know, I'm not advocating that we walk around with our mouth open, all right?
No.
We're just talking
No fly catching.
a few millimetres,
Okay.
okay?
And we can do that with our lips closed as well, right?
We can, because with our lips closed, we tend to breathe through our nose, and there's a lot of health advantages to nasal breathing.
I'm sure you work with other healthcare practitioners as well, because obviously in this area there's a lot of things going on, you know, including the ears and including the teeth. So
Sure.
what practitioners do you find that you work closely with?
Well, lots of people who come and see me with jaw dysfunction might concurrently have what we call otological or ear symptoms.
Okay.
Stuffiness, fullness in the ear, like it feels like it's got water in it or something like that. And most of those have already been to maybe their GP. They may have been referred on to an ear, nose and throat specialist, etc., etc. So sometimes we work with that group. Obviously, if someone has an obvious grinding habit, their dentist will often pick up wear and cracking of their teeth, as well as effects on the gums, etc.
Effects on the gums.
And will possibly suggest to this client that they're grinding at night. Then it's a matter of trying to understand why they're grinding at night.
And that's a whole different.
Yeah, and that might be because they're not breathing correctly at night. It might be because they have significant psycho-emotional or upregulation of a part of their nervous system, which is in so-called hypervigilant or fight or flight mode. And that is creating undue muscle activity at night because their brain is preparing them for action. That's what that fight or flight thing is, so-called sympathetic dominance in their nervous system. So understanding why they might have those issues is important, and that might be in the realm of a psychologist or someone who's in the mental health field. Obviously dentists as well. There is particular streams of dentistry that focus more on the use of dental appliances and dental procedures to help jaw joints. The average dentist is not particularly specifically trained in that area. And say, for instance, if you go to a dentist and they say you're grinding, they may offer you what's called a night guard or a night splint. And they may imply that this is going to help your grinding, etc. Whereas really, it's just a tooth protector, usually.
Which is important, but it's not going to stop the grinding.
No, well, if your complaint is a jaw problem, then pain and dysfunction, clicking, etc., then it's probably not going to make that much difference to that. There are other more specialised types of intraoral appliances, ones that put your jaw into a different position at night, so-called mandibular repositioning appliances. These are more in the realm of specialised dentists who work in this area a lot. Psychologists, dentists, ear, nose and throat specialists, GPs, all of these have their role to play. Other physical therapists, every physical therapist has got their own way of applying various techniques and things like that. So
in regards to treatment of the jaw or management of the jaw, has been some of the changes that you have, major changes that you've made over the years to how you go about managing those patients?
Well, the philosophies around what caused jaw problems within our profession, the manual therapy professions, the dental professions, etc., has undergone quite a lot of evolution over the last 40 years that I've been in practice. There used to be an emphasis that jaw problems were related to the way the teeth came together, so-called occlusion. For a decade or two, I suppose a procedure known as gnathology, which sought to grind down certain high spots on certain teeth, etc., to try and make the teeth fit better. This was something that has subsequently been proven to be not particularly important in helping jaw problems, because there's people out there with terrible bites who have never had a day's jaw problem in their life. And there are people out there with perfect bites who suffer jaw problems all the time. So I'm not saying that occlusion's not important. The other thing that's also the research has shown is the relationship between chronic TMD, temporomandibular disorder, and the state of your nervous system. Temporomandibular disorders, along with a lot of other disorders, things like irritable bowel syndrome, things like chronic intractable headache, etc., are now being thought of as having a component of what we call central sensitization in the nervous system, meaning that when we feel pain in our body, it's actually not so much that we have pain receptors where we feel the pain. We have receptors, parts of little nerve endings, which tell your brain or give your brain information about the way things are functioning, or if there's tissue changes there. But it's up to parts of our brain to actually label that as pain or not, according to the brain's understanding of what might be dangerous for you as a person in terms of your survival, your functioning, etc. And in some people, and there are particular profiles of people or patients that have this greater tendency for their brain to label that information from their body as pain. And these people often suffer what's called chronic pain, which is that they experience or suffer pain, but yet there's no objectively demonstrable pathology or damage or dysfunction in their body which explains that pain. And it tends to go on and on and on, even though the function of the part that's painful may actually be a lot better, or it might be improved with therapy, etc. And it's because it's the way that their brain processes this information that determines whether they suffer the experience of pain.
So it's a processing challenge.
Exactly.
Versus
and so
a structural or a mechanical one.
Those people have a nervous system dysfunction.
A nervous system dysfunction. Okay.
Rather than a jaw dysfunction.
Right, but they still might come into you telling you that it hurts here.
Yeah, this is where it hurts. Okay,
Right.
or they might have headaches. One sort of hint that these patients may have chronic pain these days, or the term used to be used, fibromyalgia, is now called chronic widespread pain, meaning
Okay.
CWP. They have pain in more than one area of their body that's ongoing. And those are the sorts of patients that many TMD is now considered to be possibly one of those central sensitization syndromes. And so we need to be able to recognise when a patient's problem is associated with a mechanical or some sort of pathology locally, which we're all trained to treat, or whether in fact it's a central nervous system issue, in which case we need to address our attention to the state of the central nervous system as opposed to the state of the joints and muscles and nerves and things, which are important, but in certain patients are not as important as the way that their brain works.
So it becomes a priority of treatment, right? And that the nervous system becomes first priority in terms of the mechanical strain.
Exactly.
Of the patient.
And so we need to treat them holistically. And I suppose this understanding of holism, to get back to your original question, is the way that treatment of TMD has evolved over the times that I've been in practice.